second thing is that some of the clinical features, they are not neurological features. So we as a neurologist, sometimes we skip that and we need to be aware of it. So we think about extra neurological feature, and this is what I'm going to highlight. And the issue of a pattern recognition, as we discussed yesterday, is so important. And this is a landmark article about the diagnosis of Parkinson's, and it clearly highlighted that we use pattern recognition for diagnosing patients, even more than the diagnostic criteria. And this even applies to myself that I don't exercise the clinical diagnostic criteria like MDS, PSP criteria in my own clinical practice. We use pattern recognition and you try to spot it, and we're going to highlight which feature is quite characteristic for diagnosis certain Parkinsonian syndrome. Okay, and this is what I yesterday, so I'm going to skip that. So this is what I'm going to approach here. If you look at the textbook of the principle and practice of movement disorder, you can see the classification on the left. And I find it's a bit difficult to differentiate. So this is what I'm thinking in my mind when I see patients with Parkinsonian. So I try to differentiate Parkinson's disease from the rest. And of course, we think about atypicals, but we need to think about the secondary Parkinsonism as well. And also the early onset. We need to be aware of some certain feature of the early onset Parkinson's different from the typical Parkinson's. So I'm going to highlight that as well, and the issue of the lobar responsive dystonia. All right, so this is how I'm going to tackle it. Show you some core feature of Parkinsonism. So, which one is present, which is good for recognizing it. Absence of those core features is also important. Distribution and topography we need to be aware of. And then, this one doesn't work very well. And then we're going to tackle on all these additional features in which I going to highlight a few neurological and extra-neurological features. And I'm not going to focus on the investigation because there are subsequent lecture going to focus on this imaging and so on. Okay, let's look at the core feature of Parkinsonism. This is so obvious to you. Bradykinesia, tremor at rest, loss of postural reflex, flex posture, and freezing. So this is form the diagnostic criteria for Parkinsonism, in which bradykinesia is a must, right? And but in clinical practice, you see patients with different form of slowness. So I just want to share with you that when patients are slow, they are not always Parkinsonism. This is the feature that we need to recognize is that patient with certain type of the psychiatric disorder like obsessive compulsive disorder, or patient who actually has been on a lot of dopamine receptor blocking agent, sometimes they have this obsessional slowness. And it's very different from Parkinsonism, as you're aware that when you ask patients to do something, it takes time for them to do it. So there's long latency for them to execute the movement. But when you observe them for rigidity, that doesn't exist. Okay? So this is one of the condition of the slowness that one you all to be recognized. So inquiring about the psychiatric illnesses or the presence of medication is so important here. A lot of long latency to execute the movement, okay? But patient would be able to do it. There's one condition I want to make you to be aware of. Okay? And to differentiate that from the obsessional slowness and Parkinsonism, you can see what I highlighted is that first, rigidity is not present in this patient. If you obsessional slowness, when you check them for the bradykinesia, they don't have what we call the sequence effect. I'm going to show you some example of that as well. You appreciate here when they do the tapping, it's not that there is no decrement. So that is another. I can't go very far. Okay. And the other condition of the slowness that you need to be aware of is the catatonia. And this is a feature of catatonia that has been described in the DSM-5-TR. What is obvious to you is what we call the catalepsy, which is the fixity of the posture. So you ask, you move the patient passively to certain type of posture and then remain there. It's a fixity of movement. And waxy flexibility means that it increases resistance to the passive movement. That is proportional to the way they apply the force. And that is sometimes get a bit confused with parkinsonism. But the issue of catatonia is even complex than that, and we probably might not have time to go onto it. The reason is because that patient catatonia is such a vague term with those features that I share with you, show you. But it doesn't mean that catatonia is a separate entity. It's a condition in which in patients with severe parkinsonism, they can be catatonic as well. So it's very important for you to realize. But this is a video from Fan. It differentiates the catatonia, psychiatric catatonia, from the parkinsonism by the observing of the reflexive spontaneous movement that is tends to present to be preserved in patients with catatonia. You can appreciate here. Okay. The other entity that I want you to be aware of is the mild Parkinsonian. So this is kind of, they are not against Parkinson's disease, but it's not prodromal. That's one thing there. Mild Parkinsonian side, as the name entails, they have very subtle Parkinsonian feature. But it doesn't mean that these patients with mild Parkinsonian side, they will certainly develop Parkinson's disease. They are at risk of developing Parkinson's disease, but what study actually highlighted is that those patients with mild Parkinsonian side, they tend to be associated with a lot of comorbidities, particularly vascular disease. So when you see patients with mild Parkinsonian side in which the feature doesn't fit with the diagnostic criteria of Parkinson's as yet, you need to look for the underlying comorbidities, which is very common and associated with a patient with a mild Parkinsonian side. Okay, so I just want you to be aware that this is very common. You see the elderly, 25 to 40% of those they can have this mild Parkinsonian side. They have associated with underlying different comorbidities. Now, the issue of the bradykinesia, this is very, very complex nowadays. And if you look in the literature, there are different phenotypes, let's put it that way, of the bradykinesia. The way to approach it, quite similar to yesterday we discussed about the dystonia. You can see that they're described by the axis. Okay, so bradykinesia per se, it means slow movement, means the slow velocity. But slow velocity in bradykinesia, they are not specific for Parkinsonian disorder. Let's look at the example here. Isolated bradykinesia, just bradykinesia alone, which is by means referring to the slow velocity, can be associated with many non-Parkinsonian disorder. For example, this patient with myoclonic dystonia, they have slow movement, they have bradykinesia, but they are not Parkinsonian. Patient with Huntington's disease, see, they have bradykinesia, isolated bradykinesia, but they don't have Parkinsonism. So I just want you to be aware of the spectrum of the bradykinesia, which is now very, very wide. So what do we mean by bradykinesia? Nowadays they are very, very complex. The phenotype of bradykinesia is very complex. We tend to ask subject to do this tapping, and we observe the decremental of the subsequent tapping. So that is bradykinesia with sequence effect, which is just only one phenotype of the bradykinesia. But in fact, when you ask patients to do this tapping, sometimes they freeze, sometimes they make a lot of errors, sometimes they rhythm is not is not rhythmic. So there are many phenotypes of the bradykinesia. This is one of the ways that we ask the subject to test for the bradykinesia is through this finger tapping, and you can all can test yourself how good you are in terms of the performance. But I just want to highlight to you here that when we test for the bradykinesia, we don't observe just only the sequence effect, and this is the way that we can be test for the bradykinesia digitally as well, but we don't have time to go into it. But this is a study, a very nice study done by Patamon. She very well highlighted this spectrum, and she put it in the way that how is this related to the disease progression of Parkinson's, and you can appreciate here that sequence effect occurs early, but the area of the movement, repetition of the movement, tend to occur when the disease becomes more advanced. So what is telling us here is that when we observe, when we test patients with bradykinesia at different stages of Parkinsonism, you're going to see many phenotypes. Okay, and what phenotype that I just talked about is the most has the highest value in terms of distinguishing Parkinson's from the control. This recent study is telling us that rhythmicity is the one that is very characteristic in terms of distinguishing Parkinson's from the control. So when the rhythm is not good, you can appreciate here that variability increase. So the variability of the tapping is also one of the features that you should look for. And this is another recent study that highlights as well that when you approach patients with Parkinsonism, you don't rely just on the single phenotype. And this is applied to bradykinesia that you look at the different combination of phenotype that just highlight. The more phenotype that you observe, the better discrimination in terms of the Parkinson's disease, the control, and you probably appreciate here the sequence effect, the rhythm, the error, and so on. Oh gosh, it's already 15 minutes left. That's still not just still in the bradykinesia, still around that. Okay, let's look at the tremor. Now, the issue of the rest tremor as the cardinal feature of the core feature of Parkinson's. I think this is a very important study because this is a pathological verification series of cases, and it tells you that rest tremor can occur in many atypical Parkinsonian disorder. 1/3 of the PSP, more than 60% of the MSA. So rest tremor per se is not specific for Parkinson's disease, but the feature of the rest tremor is telling us that they are not the same. They have rest tremor, but the feature of the rest tremor is not the same. So this is a clinical series also, telling us that rest tremor are present in a significant proportion of atypical Parkinsonian disorder. But the key thing is that the rest tremor in atypical patients, they tend to be quite subtle. It's not like the oscillation, pronation, supination, asymmetric rest tremor that we discussed yesterday. You're going to see that the rest tremor in atypical patients, they are not like the one that you see on the left. Okay, this is not the rest tremor. I just want to show you. But this is a patient who is a patient. I have to stand here, I think. This is a patient who actually with corticobasal syndrome, who actually labeled as having rest tremor. And you can appreciate here, this is probably not the rest tremor. You can see that this kind of jerky movement, sometimes they have been labeled as a rest tremor in atypical. So they are very different. They are not oscillatory. they are not pronations, supinations, and many times they are jerks, they are quite subtle. I'm going to skip here, rigidity, you all know, but just want to highlight, what I want to highlight is that just copulating alone is not enough for you to diagnose the patient as rigidity, okay? So many times when you test the patient, there's a little copule there. It's not enough for you to describe, to label them as having rigidity. You need to make sure that is a lead pipe component associated with it. So it's very important. And also, many times you can get confused with this paratonia, particularly in those who have this frontal dysfunction. So you need to be aware that paratonia and rigidity is not the same. You can skip that. The issue of asymmetry is so important for when you approach the patient. And this is a very nice study. They look at these patients with Parkinsonian syndrome, and then look at the issue of the asymmetry. And you can appreciate here that corticobasal syndrome, they have the highest symmetry rate, and less so for the group with Richardson, which tends to be very axial, right? And those with a leg tremor, patients with Parkinson's tend to have tremor in the hands, but you can appreciate here that the tremor can occur in the legs, and this is the patient that I want to share with you, that patient with leg tremor, there are different causes, they are heterogeneous, but Parkinsonian tremor is among those disorders that present with the leg tremor, Parkinsonian tremor is the most common. Okay, so if you see the onset of the leg tremor, particularly when they are asymmetric, you need to think about the Parkinson's disease as the highest possibility. And this is just the three leads to highlight that the tremor in those patients with Parkinsonian commonly occurs in the hand, but a much lower proportion occurs in the leg as onset, but still more common than other disorder. Okay, and I think we saw this yesterday, right? You have a case with the orthostatic tremor, and this is, I don't need to probably emphasize about this helicopter side, but the slow orthostatic tremor that we discussed yesterday as well is actually more associated with the underlying Parkinsonian disorder, particularly the MSA. So and the sounds may sound a bit different, right? The fast frequency helicopter size compared to the slow orthostatic tremor that has been named as a stream train sign. Okay, I want you to hear it. Okay, this is the sound of the slow orthostatic tremor. Okay, I hope that you develop this pattern in your ears, and then, okay, this is slow, and you spotted that the frequency is much lower than the usual helicopter. All right. And the series from China suggested that the 3 Hz, okay, 10 minutes left, I'm going fast. The slow frequency, 3 Hz orthostatic tremor is a potential red flag for the MSA. This is what has been just been studied and been reported. Now the issue of the foot dystonia is also can be a common presentation in patients with Parkinsonian disorder. And you can appreciate here, asymmetric foot dystonia. When the patients complain of foot cramp, is so important that you need to test them by asking them to walk and let them continue walking, because sometimes all this dystonia is actually induced, and it might not occur when they start walking. So we need to ask them to continue walking, and you probably spot this phenotype, foot inversion, toe clawing, and many times they have pain associated with it. And this foot dystonia can be a presentation of the young onset patients. The young onset, as you know, they can have a presentation more common in the legs if compared to the typical Parkinson's. They tend to have less tremor. Dystonia is a common presentation. The other presentation that I want you all to be aware in those young onset is an exercise-induced dystonia, particularly when it presents asymmetry. So this is the feature of the different form of the foot dystonia. Just want you to see briefly. It might occur first thing in the morning, and you can appreciate here that the asymmetric foot inversion associated with pain is very, very can be very common in the young onset patient, and it can be action induced, like in this patient when she starts walking, and you can see, you can appreciate that. And this type of patient, like this patient, when I asked her to walk backwards, what's going to happen is that the dystonia goes away. So she came to the clinic. She said that when she walked, she had this twist and painful. In order to get rid of this pain, to walk, I have to walk backwards. And she walked backwards, and the dystonia went away. And paroxysmal exercise-induced dystonia can be a feature of the early onset patient. And I just want you to see the phenotype. And this is from the case series of the exercise-induced dystonia. And you can appreciate here that a bit of the foot inversion. And this is a little toe clawing that you can appreciate with a slow motion of the video. But the exercise-induced dystonia, in fact, there are many etiologies. Not all of them are young onset patients. Group 1 deficiency, for example, is to be considered a differential as well. Okay, so it's common in young onset. I'm going to skip that. Let's go on to the additional feature and just have 6 minutes left. Okay. Now I want to the first additional feature that I want to highlight here is the levodopa responsiveness. And you are aware that patients with Parkinson's, they have excellent response to levodopa, but that is not 100% true. And also a patient with atypicals, they can also have marked response to levodopa as well. And this is what I'm just saying, coming from this autopsy series, you can appreciate that 70% of Parkinson's disease patients reported to have marked response to levodopa. 16% of patients with MSA, they can have a marked response to levodopa too. However, this marked response to levodopa tends to occur just only early in the first few years of the disease onset. Okay? And usually, in those type of atypical patients, the level of the response to the levodopa tends to subside as the disease progresses, which is very different from patients with Parkinson's disease, which tend to sustain longer. Now the issue is, like for example, there has been a study looking at the group of the MSA who have a good to excellent response to levodopa. And you can appreciate here that the fewer pathology, as demonstrated by the size of the putamen, is related, it corresponds, associated with the level of the response to levodopa. And that makes sense, the fewer pathology, the fewer postsynaptic damage is associated with a better response to levodopa. So you can appreciate here that the level of pathological involvement in patients with MSA, they are quite heterogeneous. The other thing that we need to be aware of is that dyskinesia, levodopa-induced dyskinesia, can also occur in atypical patients, like you can see here. Patient with MSA, they have levodopa-induced dyskinesia, but they still remain in the wheelchair. Okay, so the level, the degree of the dyskinesia, the presence of dyskinesia, is not associated with the anti-Parkinsonian effect. Right? They have dyskinesia, but they still cannot walk. Different from patients with Parkinson's, they have dyskinesia, but they become on and they are able to walk. So this is another a feature that we all need to recognize. And this is the last 5 minutes. I'm going to go on to the red flags. And this is a figure drawn by Chilada. You remember you drawn this one? Yes. This is such a, and like this is elephant. It's so like a female elephant. Just tell that it's drawn up by the woman. But it's highlighted very well that different aspects of the examination that you need to consider in addition to just the neurological feature. And this is the definition of the red flags. I'm not going to go into details. We are aware of it. Let's look at it. I cannot walk. And it's very important that we need to be aware of the red flags because it has a clinical benefit. When applying the red flags into the diagnostic scheme, it helps with the early diagnosis of atypical syndrome. So you need to be aware of some of the features of the red flags there. I probably don't have time to go through all of them, but you can see a lot of those videos in the book chapter that Pataman mentioned earlier. The easy one is the wheelchair sign, right? Patient with Parkinson's, when they respond to levodopa, they are able to walk. Patient in atypicals, like in the C and D, they take levodopa and they remain in the wheelchair. So the first information when patients come to you is that you ask them about the effect of the medication response. It can be very, very informative and easy. Second, you saw the demonstration yesterday in the gait lab. Observe for the step width. Step width provides a very important clue. If you look at the Parkinsonian disorder that is associated with the narrow step width, is almost, always Parkinson's, I think. Most other atypical Parkinsonian disorder, they tend to have a wide step width. So step width is another feature that you need to look for, and it's very easy. When patients walk to your clinic, you just observe their step width, okay? And there's different spectrum of the gait disorder in patients with Parkinson. Early patients, you might not spot it, but if you ask them to walk in the gait map, you're going to see some abnormality subclinically. But you will recognize a typical Parkinsonian gait, right? Narrow step width, rate shuffle when they turn, reduced arm swing, asymmetric walking tremor. This is you spot as almost immediately as they walk to your clinic. And when disease becomes more advanced, they tend to have this kind of shuffle, but they lean forward. And if they walk very fast, they fascinate, okay? Many other features when the disease becomes advanced in patients with Parkinson, you can appreciate here the fascination. What it means by the fascination is that they walk and they chase their own gravity, okay? They have a low step height, and that is actually predisposed them to freeze. And you saw a patient yesterday with the freezing, which tends to occur at the beginning when they start walking. It's called start hesitation. When they turn, it's called turning hesitation. When they approach the destination, okay, thumbs up, is they have a destination freeze. And when the disease becomes advanced, you can appreciate here bend knee and tiptoeing. But you can still appreciate that step width is still narrow, even though the disease is advanced. But the only setup, the only situation in which Parkinson's disease can have a wide step width, have limited, is when they become apraxic. This is a Parkinson's patient who is during the on time. You can appreciate here that their movement is better during the on time, but the step become wide. So they're now apraxic. They have frontal problems, so the step width changes. Okay, I'm going to use 2 more minutes, if that's all right. I'm going to highlight gait in atypical disorder, and you can appreciate here, patient with PSP, very wide step width. Even at the beginning, okay, and they use upper limbs to support them, okay. They put pressure into the forefoot quite early, okay, and this lower one is a classic video of my professor, okay. You can appreciate here the posture of patients with Richardson syndrome. They are erect, they're not countercoming, okay. That shoulder is a reduction. And when they walk, it has been described as a drunken sailor gait. That is a description. And with the impulsivity, they have the impulse when they try, they always try to, they have the impulse. So it has been described as a rocket sign. Okay, in MSA, again, they have wide step width, okay? And they can have axial postural abnormality. And you appreciate here that they can have this PISA syndrome, in which the generic term is called lateral flexion of Parkinsonism, and orofacial dystonia, particularly when they are exposed to levodopa, can occur in 1/3 of patients with MSA. I think I'm going to stop almost. This as the last slide. And you need to inquire about the onset of falls in patients with Parkinson's. This can be very, very helpful. And this is a series again from the postmortem. We all realize that the falls occur early in patients with PSP within the first year, and in the diagnostic criteria is the first 3 years, and it's followed by the MSA, corticobasal, and Parkinson's. They have falls much later, and we are aware of that. I stop with this slide, and Tatamon, this is your study. And also the way that the patients sway can be very helpful. Patient with PSP, their sway tend to be anterior posterior with a postural abnormalities. Parkinson's MSA tend to be mediolateral. But Parkinson's disease, in fact, I think that it can be either way. But falls in Parkinson's tends to occur when the disease becomes advanced and they tend to fall forward. But I think the degree of the sway when they walk can help with the differentiation too. I think I stop here because I'm going beyond 30 minutes. But I can, if the time's allowed later, I can show more videos later. I put a lot of clinical signs of Parkinsonism here. Okay, thanks very much.